years of research and work and evidence-based that medication-assisted treatment has definitely come to the fore. There is a real support by reducing cravings, which drive a vast number of people who we will see in our clinics, that the cravings and the fear of withdrawal drive people to continue to use. And it becomes a common frame with many of my patients. Yeah, Jeff, I was trying to stop on my own, or I was trying to ease off of my use of whatever opiate that I was using, whether it was oxycodone or fentanyl or morphine or heroin. It didn't matter. And so there's this constant search for assistance. And what we have found is that with buprenorphine being the partial opiate agonist, it really restores brain function, allows people to think clearer and have better executive decision-making functions while they are reducing the cravings to virtually nil. And it's so interesting to watch when the patient uses the Suboxone correctly and they're prepared for it, that all of a sudden it is like, I've been quoted, it's like somebody finally threw me a lifeline. I was in withdrawal, my COW score was elevated, I was feeling crappy, and then all of a sudden I used the Suboxone correctly, just like I'd been taught, and again, it was like somebody threw me a lifeline. And some of the common myths. Are there any questions so far, or shall we wait to the very end?
It looks like we have one question. Keith?
Go ahead, Keith. All right.
Okay, I got it now. Okay, the question was, in your mind, does the Suboxone and methadone, does it need to be paired with behavioral counseling actually at the same time?
Absolutely. That is such a brilliant question. And there were in several years ago, the two frames of addiction medicine, and one was purely MAT based, and the other was purely talk therapy and abstinence based. So we'll go over that in one of the myths that really figures prominently. But I am a former military. I believe you go into battle with all of your ammo, and I think a well-rounded patient and a well-rounded clinician work to the utmost for the healing of this disease.
Thank you.
Sure, sure. So let's go to the myths. Okay, so many of my patients who are now going to group therapy or NA or AA, and there is still the old stigma, and I'm probably going to go back to stigma, and hopefully today's webinar will really blast stigma out of the water and make us all much more compassionate with ourselves, with our practice, and with our patients and family members that we all encounter. So what we're finding is that without medication, and this is evidence-based from ASAM, American Society of Addiction Medicine, that really fewer than 5 people with opiate use disorder recover just by abstinence base. And basically every single patient that I have had that has had an enforced abstinence, i.e. jail, or they tried another inpatient and there was no medication-assisted therapy offered, had a dangerous relapse. And by what I'm saying by dangerous is you lose your tolerance from constant opiate use by enforced abstinence. So now you don't have that protective layer. you go back out and you use what you thought was the amount that you used to use all the time, and now it becomes an overdose capable event. So abstinence-based treatment has shown that there is a real 90% return to use rate. And one of the most poignant things when I was first starting in MAT was a guy who walked from the jail, which was less than 5 blocks away from my office in Everett, Washington. And he said he passed 2 dealers, 1 shot house. He said if he hadn't been able to make it to my door, he would have probably used. And he had, when he came back several days later to continue our work with MAT and some more talk therapy with me and cognitive behavioral therapy, he was in tears again that he had lost his best friend who had not made it past that same route and had used and overdosed on fentanyl. So what I wanted to address with Keith is that, yes, once you develop all your available modalities, or you have talk therapy, you have sponsorship, mental health treatment, you start paring away at the adverse childhood events with trauma-informed care, and you delve into that. What the MAT in the beginning allows your patient to have clarity of thought and feeling of support that you are then able to develop more cognitive behavioral therapies. So does that answer pretty much everybody so far on myth number 1?
Yes, that's for me.
Great. All right, let's hit myth number 2. And I hope you guys don't mind, but this is not going to be a hit or myth kind of program. Sorry. Anyway, myth number 2, you can get high on Suboxone. Well, if you're opiate naive, you could, because it is a partial opiate agonist. It does access the mu receptors, but opiate naivety is very rare in the patients that we have. We may have somebody who's been incarcerated for 7-8 months. Then they would be considered opiate naive again, and that's where you have the discussion with your patient. Let's be careful. Let's use the Suboxone as protective so you don't run the risk of getting fooled by your old usage habits. Many of my patients liken the feeling of using Suboxone as clarity of thought. I have this one wonderful patient who has been struggling with substance use disorder for at least 25 years. She's been incarcerated many, many times. She says, once I finally did it right and had you supporting me, Geoffrey, it was like I was myself before I ever tried any kind of chemical, whether it was alcohol or meth or opiates. I just feel back to my old self. And it was those memories to allow her to have better clarity of thought. The euphoria that she feels is the euphoria of being healthy again, being able to being counted on by her family, getting her kids back. So that is one of the things that I think we all ought to keep in the back of our mind. There is a feeling of normalcy, the euphoria of being back on track and in control of your life. The reason there is a combined, well, Suboxone is the combined medication. It is the buprenorphine that will partially agonize the mu receptors, and the naloxone is designed to prevent just straight buprenorphine, which was also known as Subutex, from being diverted or used as a euphoric agent. And so it was designed to have the buprenorphine and the naloxone together so it couldn't be tampered. It would provide immediate withdrawal symptoms to prevent abuse. Are we ready to move on to myth number 3? All right, I get a number of my patients who are now feeling good. They are back into where they want to be. They're designing their life path. They're learning more lifestyle modifications. They are able to engage. They're working again. They've got their kids back. They're getting their legal entanglements unencumbered. So they're doing really well. And then I get this question, and it's a wonderful question. So am I going to be on this all for the rest of my life? Well, as a practitioner, I deal in facts, and it's hard to prognosticate the future. So it's like, you know what? That's a great question. I wonder if you're a diabetic and you're on insulin and metformin and glipizide and glyburide, and we start working on your diet and exercise, and you start paring down, doesn't that give you more control with what you're left with? Maybe you don't have to take insulin anymore, and maybe the glipizide can go away. And so now you're managing your disease in a very controlled manner. And I liken that to the use of Suboxone. And if my patient many times feels like, oh my Lord, I have more control. Hey, Jeff, let's go from 16 to 14. Let's see what we can do. And we do it for a few months. And then they're like, you know what? I didn't notice anything. Can we go down? And so that feeling of advancement, I think, really supports our patient's aspect of control. And again, remember, for as long as you've been using opiates, you're going to probably need a like period of time to develop your lifestyle modification and your use of the medication itself to help you in that pathway. I really like to be a coach with my patients along their paths. That's why I find one of my more successful modalities is really engaging my patients to take stock every day when they dose. It gives them a real good time frame in which to get centered with themselves. Usually in the morning, they put the Suboxone under their tongue for 30 minutes. Prior to that, they've prepared their mouth and their health initiation by drinking some warm water. Their blood is flowing, their vessels are dilated in their mouth, and then they put their head down, keeping the saliva swishing around and getting into the bloodstream. So use that time very advantageously by writing in a journal or finding something that they're passionate about and studying that passion so we can have more cognitive behavioral, dialectic behavioral therapies to talk about at our next meeting. All right, so let's move on to myth number 4. And I've had a number of patients say, hey, Jeff, this crap's harder to stop than heroin. Well, I wonder if that is a kind of self-protective thought process, because I have not seen my patients who, it kind of started when I noticed this attitude about 3 years ago, when my patients were doing very well, got new jobs, and a gentleman went out of the state. He couldn't get in to get the Suboxone, and we got calls that he was really suffering dangerously, is what he said. And he said, this is the worst withdrawal I've ever felt. Well, when he came back and we got him back on his dose of Suboxone, looking at his journal, what it was he was scared and not trusting himself, and he kind of gave himself an enforced incarceration just work and going back to the hotel, so he wouldn't be tempted to go get an opiate. And I think there was a real strong emotional tie to that as well. And it kind of bore out. The more I had more of these successful patients than having missed appointments or being on a vacation or whatnot, losing medications, they would discuss that. But by and large, once we talked them through it, we showed that a stepwise and very gentle weaning program, there were no withdrawal symptoms ever noticed in the vast majority of my patients. Are there any questions right now? I kind of went through that one pretty quick, but it's pretty straightforward. Anyone? All right, let's move on to myth number 5. And I have been working with the city of Everett since I started at the Everett Clinic almost 5 years ago. And there was so much stigma around a office-based clinic. In that very neighborhood had been the one of the pain clinics that had turned itself into a pill mill, and the proprietor and doctor of that was put up on charges, and so many people with stigma in their minds, not understanding the disease of substance use disorder, kind of levied their feelings and saying, oh my God, there's so much crime around these office-based clinics. And even a number of my patients who had said that they had been on methadone in the past, and they used to have a well able and desirous population in a methadone clinic to buy their heroin. But the complete antithesis, the opposite, is what I've noticed in our clinics here. You go into the waiting room, and I've had so many of my patients say, you know what, this is a completely different waiting room than other places I've been. People are bright, they're willing to say hello, they are talking about very openly and honestly about what has happened. So we make it a point in our clinics to go out and address everybody in the waiting room once in a while. Like on a rainy day, we'll have a quick weather check. If I have seen some of the newer patients throw cigarette butts out, I will admonish them like my old drill sergeant ways. And many of my long-term wonderful patients will go out and also lend their ability. I've had people ask for bags and gloves and gone pick up cigarettes, but I have not ever seen any needles discarded out in front of our clinics. I have not witnessed any type of crimes. There has been the occasional upset patient who slams a door, but that's usually in the very beginning of their treatment. And so we pride ourselves to create a very compassionate and calming clinic waiting room, and to have a very open and honest discussion centered around the Suboxone, MAT, as well as an engagement of people in our clinics to be compassionate to one another. If they see somebody, let's pay it forward. We have instituted a number of letters, anonymous letters, that patients can say, oh my gosh, you know, I had some sleepiness, and there's somebody wrote a letter. Dear patient, I used to have problems with insomnia when I first started my journey to long-term recovery. And so that's been a work in progress. So definitely I have not witnessed criminal activity, crime, loitering, and by and large, the patients who are supported will support one another as well. And let's try diversion, the myth of diversion. The Suboxone is going to get out on the street. Well, I do believe that there is a small market, and I do believe that some people will sell or give away their medication, but all prescription medications. How many times has grandma not used her antibiotic and given it to, you know, Mrs. Machutek because she has a urine a UTI, urinary tract infection. I mean, it happens. We are diligent, and we do institute a number of protocols that we trust yet verify. We utilize urine tests to ensure the best practice of medication adherence. So it's really interesting because ASAM, American Society of Addiction Medicine, has done some evidence-based research on that, and they have seen that when Suboxone is diverted, it is most commonly sought by people who are trying to get healthy again and to alleviate withdrawal symptoms, and that becomes a perfect entry point for somebody to say, you know what, why buy it on the street when I can go to a doctor's office and talk to somebody and really get into a program that gives me more control and identifies my disease. So let us do myth number 7. Okay. I have worked now for about 3.5 years with the jails in my county and my city. And what's very interesting, in the beginning, the stigma was there among the staff of the jail, feeling that why are we helping these people alleviate their withdrawal symptoms, because the old manner of thinking was, well, if you have to go through withdrawal, you're never going to want to do it again. And that's patently untrue. It doesn't help. We work in a strong harm reduction attitude and philosophy. Some of my very best programs of education has been with the jail staff, the sheriff's deputies, the nurses in the health end of the jail programs. So what we are doing, again, in the harm reduction, is if people can start with medication-assisted treatment in the jail, they are more likely to go and find the program once they get out. And we've instituted a number of warm handoff programs that are working tremendously well. It also has an ability to stop, and I've heard far, far, far less examples than my first patient, who was so worried about walking from release of the jail up to our office, use drugs, and run the risk of death or overdose and further illness that is concomitant with IV use or inhalation use. And so the risk of injury and suicide during incarceration when somebody is withdrawing is elevated, but when they are supported by Suboxone, it is greatly reduced. And then everybody was talking, when I first gave my talks at the jails, that the burden on the correctional and the janitorial staff. Well, let's be serious about that. when they were detoxing and just vomiting and diarrhea all over, that's a huge burden on the janitorial staff. You provide a medication that alleviates that right from the immediacy of 24 hours into withdrawal. You start the Suboxone, and the withdrawal symptoms are alleviated immediately. And then the correctional staff, after they started listening to the classes that I was giving and started working with the people that we were inducing with MAT in their initial incarceration, said, you know what, they are so much more clear-minded, clear-headed, and they are easier to work with. And it became a real meeting of the minds between the incarcerees themselves and the correctional staff themselves. We also, again, I'm going to harp on that harm reduction model. There is such a high risk of overdose death after release with just straight detoxification without that medication-assisted treatment. And then you, pardon the pun, you have a active audience, you can initiate some of the lifestyle modifications. And I've seen that work incredibly well with a number of the programs that have been instituted in our jails up here in Snohomish County and the city of Everett. We've also been working with the COET teams in Everett and the Office of Neighborhood teams, which is essentially an officer and a social worker that have been partnered, and they go out and offer support and not just arrest and jailing. And we have seen the reduction of crime and recidivism by large numbers here in the city of Everett and the county of Snohomish. So I think I have gone through that as concisely as old Jeff is able to. And I'm wondering, let's open this up to some questions. Let's get a real good talk going today.
Yeah, this is Keith Madsen again.
Yes, Keith.
I was wondering what the effect the COVID-19 pandemic has had on people in recovery, given the need for social isolation.
Sure. Well, as we all know, and I'm really poignantly aware that within my patients who suffer from any kind of substance use disorder, there is an aspect of social isolation because, one, their family members have kind of moved away from them. They feel embarrassed, and you know all the attendant problems within what we treat. So what I've been trying to work on with my patients is let's open up a frank discussion about how this COVID is attenuating your fears. Is it kind of reopening, reawakening, or reopening old wounds of fear and paranoia, or feelings of childhood injury? How are we going to work together? And I've seen a number of my patients with their journals have these really sweet kind of entries that they are going to make it a point to reconnect with families through television, telephone, or through social medias. And so we're kind of evolving into how we can support our patients and support family members and band together in this unprecedented time. The other thing, my patients make me a better practitioner. And I had this wonderful patient who has been, she's going to have 4 years on July 11th, so 7/11. And she knows my stance against anti-sugar and soda pops. But I told her that I will take her July 7-Eleven, to a 7-Eleven, and I will buy her a nice big bottle of water to celebrate her 4 years of long-term recovery. But what she said to me in her journal, and we were doing this over Zoom, that she has finally gotten her kids back about a year ago, and said, now with COVID, I've got all my kids at home, and I'm afraid that they'll figure out that I'm a fraud, that I'm not smart, and that I'm not this, and what's going to happen. And that was such a poignant fear and worry that she was able to express to me honestly. And I said, okay, young lady, what are you doing at home with your kids right now? Well, we're making fruit roll-ups and we're drying fruit. And I said, okay, so why not have your kids write a COVID home-based recipe book about how to make fruit roll-ups and use math. So if they're making fruit roll-ups for a family of 4, or they're making fruit roll-ups for a family of 12, how would you mathematically do that? And her kids have they just think mom's brilliant. And so those are the kind of things that we can do together to come up with ideas that are innovative, that are compassionate, that are loving. And I really think this is a perfect time that we can just spread our wings as providers, whether we do more supportive measures behaviorally, change up lifestyle modifications, and use this time as a strengthening time for all of us. I do believe we're going to come out of this, and I do believe this is our defining moment in history, that why not make this generation's New Deal, a healthy New Deal. So there, I just got off my soapbox.
Do you have another? Does that help, Keith?
Yes, it does. I had a follow-up question, if I might, and that's the relation, again, between the two pandemics. I'm concerned that, the death toll from opioids reduced slightly in 2018, but I'm concerned that with all the need for medical facilities, with the coronavirus pandemic, that those who overdose from opioids may not be able to get the care, and that death toll might go up again. Can you comment on that?
I think for all of us providers that we need to be very sensitive to that, and I think maybe I'm going to want to go back to my old textbooks on the public health aspect. I do also encourage my patients to maintain social distancing, to maintain really good hygiene, maintain a healthy lifestyle. So if they're smokers, this is now the time to stop smoking, because as we know, with COVID, people who smoke regularly are at greater risk if they do get the virus to have a bad outcome. So this now becomes my caveat and my entree into, let's have that discussion. I've been wanting to have that discussion with you, Billy Bob, for months, but now this is really time sensitive. So let's work on that. I've learned a number of methods with all my wonderful patients to develop a open-ended public health statement from person to person. So I hear your concerns, Keith, and I suspect that everybody on the webinar this morning have very, very similar concerns, and I suspect we are all sensitive to that. However, if we can just maintain the banner of good health, listening to the government as to what they come up with at every step of the way. So the social distancing, Essential travel and unessential travel should be negated. Learn modalities of staying healthy and supporting one another. I think social media and support through social media is going to become paramount in the fight against both of these pandemics. And you're absolutely right, Keith, to list substance use disorder as a pandemic, especially in our country. I could go on another soapbox, but I think that should wait for another time, whereas we were so invigorated by working with opiate use disorder, but what about alcohol use disorder? And what about methamphetamine use disorder? And then what about cigarettes? And what about sugar? I mean, we have all these modalities that can get us unhealthy. I think the question becomes, let's really put forth health as we work with our clients.
Thank you.
No, thank you for your wonderful questions, Keith. Anybody
We have
else?
we have another question from Emily. She's wondering, what are the options in a jail setting for administering Suboxone? She's heard from jail staff that they're concerned about people cheeking it, like keeping it in their cheek and then passing it on to others, and the amount of time medical staff would have to spend administering it. Can you talk a little bit about how we administer Suboxone in jails?
Sure. Oh, I'd love to do that. I had a lot of fun talking with the jail nursing staff and medical staff, and that was a prime worry. So let's look at how the jail is getting the medication. Are they getting strips or are they getting tablets? Well, primarily the tablets were less expensive, so the jails were using tablets. In one of the jails I had spoken to, I worked with their medical director, and we decided to crush the tablet and put it into the mouth after drinking a good 12 ounces of warm water. So the patient will drink the warm water first, their saliva will be accentuated, then their mouth will be much more moist, and then they place the crushed tablet under the tongue. We did run into an issue where the pharmacist of the jail said, "Oh, you're not allowed to crush it." However, in this time, we noticed that there was no cheeking. There was the deputies noticed that there was far less of a stock and trade. And with the other jails that I've worked with that do the tablet administration, what we would all do is we would begin the we would have six inmates with 6 feet of each other in the bay, and then the patient would identify, or the inmate would identify themselves. The nurse would provide the correct dosing after the drink of water. So she would hand the warm water to the incarceree. He would drink it, and then he would show his tongue. She would give it to him. He would place it. She would see it laying on his tongue and it would begin to dissolve immediately. And then she would have him close his mouth. Then she would go to the next patient and repeat that. So those were, and it did not increase time of administration, and it worked quite well. So that's how we addressed those. Does that answer Emily's question?
I think so. Do you want to talk a little bit just about us, Jeff, and then we can open it up for more questions?
Sure. Like I said, I came out of retirement. I was doing pain management. I was very outspoken in opiate-induced hyperalgesia. We were providing way too many opiates for people. I decided to get out of pain management, and I met the two owners where Ideal Option had started in the Kennewick, Pasco, and Sunnyside area. We got to talking, and I just realized that their vision and their compassion for patients was exceedingly great. And I decided to stay with them, and they allowed me to kind of run and increase our Everett location and size. In the almost 5 years I've been, they've grown from like, I think it was 14 clinics to 65 clinics in 8 states. We have 31 locations in Washington State, and we're all predicated on a harm reduction, very compassionate model. We believe in the fullness of substance use disorder long-term recovery through evidence-based MAT, medication-assisted treatment, as well as good cognitive behavioral therapy and dialectic behavioral therapy and mindfulness techniques. We also predicate ourselves in low barriers. So no wait lists. I have taken people right in off the street. We put them on the phone, they call the call center, and we get them an appointment. I do say, you know, I'm glad you came in. I've got a lot of patients in my waiting room, and so you may have to wait about 2.5 hours. That's okay. We got water here, and you can see one of successful patients walk in and out for their appointments, but we'll get you in. We have no financial barriers. We take all insurances, and we do have financial assistance. But as I tell my patients when they ask me some of the financial questions, look, I think I'm a really good practitioner, and I love doing medicine. I love understanding pathophysiology. But you ask me about finances? Oh, let me get you to the right person about that. There are no overnight stays. This is a regular doctor's office clinic. But I do offer to my patients, especially some of the ones who are feeling fragile, come on in, just sit in our waiting room and we'll try to help you. Now, in the time of COVID, we're not able to do that. But I've had a number of patients who feel that that our waiting rooms are a safe place. And so we are outpatient clinics, and all the patients in the waiting room get to see one another in a wonderful milieu. And so we're not your typical residential treatment, but we do connect with residential treatments, and we have wonderful partnerships. So I think that's another key about Ideal Option. And then the last thing I'd really love to talk about is no penalties. I remember I had my epiphany about substance use disorder many years ago, and I recognized that I, as an ER nurse and a former, drill sergeant in the Army and have been a medic in the Army, yeah, I was kind of punitive. But when I realized and I saw that stigma needed to be broken, it needed to be eradicated, and it needed to be done with compassion and acceptance. So what I felt is we as Americans, especially in medicine, tend to have a pendulum, and that pendulum will go from very conservative to very liberal, or however you want to look at it. I really like to be in the middle. I like to accept my patients exactly where they are at. They tell me where they sit, where they are at. I will accept them and listen to them for where they are at. However, I will offer, and I do like to show them that accountability is also very key in their recovery. So we try to get both no penalties, yet a good sense of self-control, self-assessment, and self-direction through our coaching. Did that answer everything, Melody?
Yeah, do you want to just talk really quick, see the screen up, just a few things about how we're responding to COVID, since that's on everyone's mind right now?
Right. Okay. So I love online recovery groups. We have a little Zoom that's been just started with me, and I get to reprise my old career path as being a DJ and on-air personality. That's kind of fun for me. But my patients keep calling in, and they're having this wonderful discussion amongst themselves about how they are addressing all the pitfalls that are happening through this COVID pandemic. We are also now setting up virtual visits, especially telemedicine. We've been doing that in the clinics. I am seeing patients from here in my office at home to my patients that come to the Everett Clinic or other Washington State clinics. We also have been working with a device, mobile device, in their own home work. And I would like to keep that kind of in the fore. We need to identify the most successful patients who would work with just staying in their home. People who have a good internet connection, people who are able and willing to get on to, we've been using Duo. So this is just starting, and I think it holds such great promise for this pandemic. And then what else? We're all going to take we're going to be taking everybody, new patient, existing patients, through the mobile telehealth patterns and opportunities. So I think I've addressed everything in that realm. Rose or Melanie, anything else you think I should cover?
No, we have, let me see another question from Emily, a follow-up on the jails question. She says jails and prisons often do not allow people to continue their Suboxone regimen when they're arrested. People on parole are often afraid to let their officer know that they want to be on a Suboxone program. Even some drug courts have told participants they can't continue their Suboxone program. What rights do people have when it comes to accessing this medication?
Well, I believe that is an essential right, an inherent right. Do jails stop providing insulin or metformin to diabetics when a diabetic is incarcerated? So I think that is the stigma that is kind of getting broken down with Emily. That's a great rejoinder. I really appreciate the fact that you bring that up. And I've been able to talk to a number of judges. When I first started, I made sure to go to as many of the drug court judges to tell them what we do and teach them about the disease and how a partial opiate agonist is so much better. I think what they primarily rail against is the methadone treatment in jails. And it's, again, that old stigma of you got to own your detox. You got to feel like hell, and that will make you not want to use. Well, that old sense and that old thought process has been shown time and time again to be an erroneous idea. So we can't incarcerate, we can't jail the addiction out of people. It just doesn't work. So if we can use incarceration as a good entree to getting into more health, more medication-assisted treatment, more talk therapy, more mindfulness, then I think we really should use that entree. Emily, did that address your question? I think you, as a very sensitive provider, might want to just go out and talk to all the judges and say, I have recognized that we may have a problem here. Can we discuss this? I think there's no harm in bringing it out openly, honestly, finding out what the different deputies or leaders in your jail systems have with the program as it might change, and then talk with the judges, because ultimately they are the final arbitrator of what will happen to the patient.
Yeah, she's also wondering if we know of any specific laws pertaining to access to MAT in jails. I know that like the ACLU has successfully sued the corrections department in some states and counties, like Whatcom County up in Bellingham. Correct me if I'm wrong, Jeff, but it seems like each state is moving more towards mandating that jails and prisons allow medication-assisted treatment, as ACLU has these successful lawsuits against criminal justice systems.
Right, and as I understand it, from what I've read, and I'm not a lawyer by any stretch of the imagination, but what I do recognize is that the ACLU has really upheld the amendment right of no cruel and unusual punishment. So I think if you withhold a medication that stops suffering, that is construed as cruel and unusual punishment. So I think that's where we're coming at loggerheads between old stigma and changing stigma, and then reprising how we need to meet people with substance use disorder, and not viewing it as a criminal behavior, but as a medical disease that leads to criminal behaviors.
Great. We have another question. How do we as Ideal Option and providers work with drug courts?
Well, I like working with drug court. It gives me another soapbox, and as anybody who's been on this webinar can tell, I have no problem getting on my soapbox. So that's my natural venting. And when I get to meet the judges, and it's the most endearing thing, the most fulfilling thing is when you see public figures who really change their ideas about, you know, when they can admit, you know what, maybe I've been wrong, and let's see if we can fix this, and let's see how we can help, because ultimately it does help community, and community then ultimately does help society. And so I think by being open and honest and kind of following the banner of good evidence-based research and compassion, I don't think we can lose. And so I really love being on the front lines of helping to eradicate stigma in my case, in some minimal way.
Great. It looks like Keith has another question.
Hi, Keith. We're getting to be good friends.
Yes, I'll just add another question. You know, first of all, I want to affirm you for having this. This has been great. You mentioned about precautions you take at the clinics to guard the health in regard to COVID-19. What are some of those specific cautions that you take in that situation?
Sure. Okay, so PPE, personal protective equipment for the staff that's manning the front desk. That's paramount. Followed not even minorly, I mean, it's just like right across the board, good surface cleaning. Every time gloves are taking off, hand washing, and then the patients are encouraged to keep good social separation. It was interesting, I was still in the clinic seeing patients when President Trump's edict came over the airways that no meetings of greater than 10 people should be allowed. Well, we had like 28 or 30 patients in the waiting room. So I took it upon myself to go out and be the arbiter of President Trump's edict. And I said, okay, guys, in this fast changing time of COVID, the president just got on, and we need to separate ourselves. So why don't, I'm going to put a box of pens out here and a pad of paper. Please write down your car and what time your appointment is and your name. And one of my staff will come get you in your car when your appointment is ready. And everybody, you know, gave themselves a good 6 feet of distance, and they went up and they orderly signed where they were. And there were 4 people in the back who I'd never seen in my waiting room before. And it was obvious that their spokesperson got up and he said, "Sir, we're homeless. We don't have cars and we don't have cell phones." And he was so, it was so poignant. I mean, he was abashed to tell me that. And I'm like, okay, great. No worries. We're smart people. Let's figure this out. I said, we have a couple of extra old exam rooms that somebody can go in, and then the rest of you guys kind of separate yourselves and just stay in the waiting room. And you know, let's keep hand washing. Let's, if you've got a cough or anything like that, let's cough into your elbow, or, you know, better yet, I'm going to get you some boxes of Kleenex, and we'll put a trash bin right by you. So if you cough or sneeze into that, and then put it immediately into the trash bin, and we'll take care of it at the end of the day. And he went back, told all his people, his 3 other people, we got him into rooms, we got him socially separated. And he looked at me, he goes, "Thank you for treating me like a human being." And I mean, wow. And this is the time we all have to band together. We all have to think appropriately and treat each other with compassion and good sense.
Looks like we also put the link to our webpage about coronavirus in the chat and Q&A. So you can go to our website to learn more about how we're taking precautions and responding to coronavirus. And it looks like we're out of time for today, but we'll be sending out the recording and the slides to everyone who signed up and who attended today's webinar. So thank you, Jeff, for such an amazing job of going through these myths and answering all the questions. And thank you so much to everyone who attended. We hope that you're staying safe and healthy, and we'll email you the slides and the recording. So thanks, Jeff. Do you want to say goodbye?
Thank you. And I'd really like to thank all my colleagues that were on, all of you who were on this webinar. Thank you. And we're going to get through this. And if I can send out best thoughts and prayers to everybody, I am definitely on board with doing that. So thank you all for attending.
Great. Have a good day, everyone.
Bye, everybody.
Thank you.